We're going to be talking about colon cancer and primarily preventing and diagnosing it and focusing on preventing it. We'll start with a little bit of anatomy. This is kind of the perfect colon there. Most don't look like that. They have a few more curves and swoops and twists, but the colon is the large intestine, and that's where we're focused on. You can develop cancer in the small bowel, but it's much less common, and it's also not an organ that we can get a scope in easily throughout. And small intestinal cancer is rare enough that right now there isn't routine screening except in certain select very high-risk patients. So we're focused on the colon. This is a little bit of an older slide, but hasn't changed that much. You can see about 11% of new cancer cases are colon in the United States, and about the same in Montana. Now, the thing to know is that colon cancer is, for men, the number 2 cancer killer, and for women, the number 3 cancer killer. So even though it's only about 10%, it's high up there as far as fatal cancer. So what are symptoms of colon cancer? Well, we're focusing on this talk on preventing that, but it's important to know these symptoms and signs. So rectal bleeding can be a sign. Obviously, there are other things that can cause that as well, but that's kind of a red flag. Anemia, iron deficiency anemia particularly. Change in bowel pattern, such as urgency. If I can get this done. Diarrhea, new constipation. It's a sudden change. Most of the time, these changes in bowel pattern don't mean you have cancer, but it's worth getting checked out. And then abdominal pain can be a cause, and unexplained weight loss. And then we're going to be talking about prevention of colon cancer, and I'll leave the dietary aspects to Beth. She'll go into that more detail. But these are some of the things that can be helpful, but prevention of colon cancer. Screening tests that detect and remove adenomatous polyps are the most reliable method of preventing colon cancer. So, in the American Cancer Society. So I'm going to be focusing on this. So, again, fourth most common diagnosed cancer, 2011, about 141,000 new cases in the United States, and the second leading cause of cancer-related deaths in the U.S. So, screening, why? We want to prevent cancer if we can. We want to reduce the number of people that have cancer, that die from colon cancer, and the way to do that is to reduce the stage of presentation. So this graphic shows cancers that are in various stages. A stage 0 has not invaded into the wall at all. It's only in what we call the mucosa, the lining of the colon. Stage 1 has started to invade into the muscular layer. Stage 2 is a little bit deeper, and stage 3 is through. Stage 4 is when it's spread to other organs, and we'll show you how the stage correlates with survival. So on this, I probably should have had this a little sooner, but this shows that the rates of colon cancer are generally going down a little bit. And that's probably because of colonoscopy, people getting their screening done, and we are preventing some cancer by taking out adenomatous polyps. So why do we want to find it at an early stage if there is cancer? Obviously, we want to prevent it, but if there is cancer, we want to find it early because the survival rate is so much better than at a late stage where if you get that stage 4 where it's already spread at 5 years, only 10% of people are still alive. Unfortunately, only about 40% of colon cancers are found at an early stage. So again, here's the survival rates by stage, and you can see how it just drops off precipitously down here at the 3s and 4s. So, how do we prevent colon cancer with the colonoscopy? Well, we find these. And this is a polyp, and this is an adenomatous polyp. Now, there are different types of polyp. A polyp is just a bump, a lump, something sticking out in the lining of the colon. Sometimes it's a little bit of inflammation. Sometimes it's what we call hyperplastic, where it's just kind of like a callus type thing. It just has no real significance, doesn't become cancerous. But the type we're looking for are called adenomatous polyps. Now, sometimes they look like this. This is what we call a pedunculated polyp. It has a little bit of a stalk there. Sometimes they're flat, look like they're just kind of spreading along a portion of the lining of the colon. But we want to take those out so they don't become this, colon cancer. So here's a normal colon here. These are various types of polyps. Here's a very small polyp, kind of a multilobulated one, another pedunculated polyp. And this is a very large kind of spreading polyp. These are, when they're this big, a lot of times we can't take them out with a scope, unfortunately, but a segmental resection of the colon in that area can be done. If it's down low in the rectum, there are some newer procedures that called a TAMIS procedure, where they do kind of almost robotic surgery through the rectum to get to this area and take it out without having to do a big, extensive surgery. Dr. Murray in general surgery does this. So if this was in the rectum and we didn't think we could take it out with a scope, he could work on it in that fashion. So how do we take these out? Well, this is using snare cautery. So this is a nice and red pedunculated polyp. So we put a little wire lasso around that's connected to cautery, tighten it up, and step on a foot pedal. And we just want to use enough cautery to prevent bleeding, and it cuts it off. We retrieve that specimen to send to the lab. Occasionally, there can be cancer within these. And if it's an early enough stage, hasn't invaded into the stalk, the margin's clear, even if there's a little bit of cancer in there, sometimes just taking out that polyp is all that needs to be done therapeutically. So what are the recommendations for colon cancer screening? We recommend everyone starting at age 50. There are some groups that are at higher risk, patients that have a history of especially colon cancer in a first-degree relatives, parents, siblings, under the age of 60, then they ought to have their first colonoscopy done 10 years younger than that family member was diagnosed. If you have one family member who's older than age 60, then it's more likely just an age-related thing that you just need the standard age 50 colonoscopy. Patients that have inflammatory bowel disease are at higher risk. So patients that have ulcerative colitis, after about 6 to 8 years, if their whole colon's involved, we start looking every 1 to 2 years and getting biopsies to look for any changes in the cells that that could be on the road to becoming cancerous. Anyone that's had polyps is considered at that point then at higher risk. And I'll talk a little bit more about what those recommendations, adenomatous polyps, I'm talking about the precancerous type. So who else should get a colonoscopy? Well, you could be younger than age 50, or you've already had a colonoscopy, but say it's 7 years after your last one, didn't have any polyps, but you have some new changes. That would be a trigger to get one done sooner or earlier than the standard recommendation. So these are all symptoms, signs that would warrant having a colonoscopy. Now, what kind of screening is there? Well, I've mentioned colonoscopy. We'll talk about that. There are other methods. One of the ones that is done more commonly now is the FIT test. It's a fecal immunochemical test to look for blood in the stool, because one of the early findings with colon cancer would be a little bit of blood in the stool. Often these are what we call false positives, where something else is making blood in the stool, whether it's hemorrhoids or taking an aspirin a day can cause a little bit of irritation in the stomach, can make that test positive. But if it's done for colon cancer screening and it's positive, then you go on to a colonoscopy. It's useful in screening large groups of patients. Now, some of the things that can be done where colonoscopy isn't really available would be a flexible sigmoidoscopy, and then perhaps with a barium enema, because a flexible sigmoidoscopy only examines the lower part of the colon. This isn't done that much anymore, but is done sometimes. And occasionally, someone will have a polyp that's down low that we need to check on sooner, but don't need to really put them through a full colonoscopy, and we'll use a sigmoidoscopy to do that. So now, if you have a negative screening colonoscopy, then we say 10 years later. People always latch onto that 10 years, and then we find a adenomatous polyp. They fall out of that average risk scenario. So fecal occult blood testing can be done with the FIT test. This is the older type with the cards, where you would put a little smear of stool and have it develop to look for blood. This is the newer one, the FIT test. It's a little bit more accurate, more sensitive. Sigmoidoscopy, again, only examines those lower parts, so we don't think that's a great screening test because you leave this much of the colon unexamined, but it's better than nothing. Used to be done fairly frequently without sedation. Still can be, but patients don't really like that very much, so we try and avoid it. Barium enema, not used very much anymore for screening. One situation where we will sometimes use this is if someone occasionally we'll have patients that have just really long colons. We kind of run out of scope, or they have twists and turns where we just can't get it to advance to the end of the colon. So we'll use a barium enema to examine that part of the colon that we can't get to. And then colonoscopy, where we go all the way around the colon. A lot of times we'll go into the very last part of the small intestine just to take a look there, but we can examine in 98% of patients or so the entire colon with a colonoscope. Yes, ma'am?
What's the little thing hanging off the end of the colon there?
Oh, the appendix. Yeah. So
It's attached to the colon.
it is. So one of the landmarks we use when we get to the end, we'll see the little opening for it. So it's, the question was, what's the little thing hanging off the colon? It's the appendix. You're welcome. All right, now what about virtual colonoscopy? You may have heard of this. It was, you heard quite a bit about it a few years ago. And basically, it's a non-invasive way of examining the colon quite well to look for polyps. So it's called CT colonography, virtual colonoscopy. And how's that done? Well, you have to do a prep, just like you do for a colonoscopy. You have to get cleaned out. And then they insert a little catheter into the rectum, kind of blow it up with air, and get a CT scan, and then reconstruct the colon using computer generation to have then the radiologist basically takes a little trip down the colon, just like a colonoscopy, and looks for bulges sticking out into the inside of the colon that could be polyps. And then the problem with that is then you need colonoscopy if you find anything. It's less invasive. You don't need sedation. It's not very pleasant, as you can imagine. You have to do the prep. You have the air in there that's uncomfortable, and you're not sedated for the procedure. And then, if you find anything that may or may not be a polyp, because it could be like a little piece of stool or something stuck, sometimes they can't tell, you have to have a colonoscopy anyway. Medicare doesn't cover this for screening. Occasionally there are patients where you, for whatever reason, maybe a lot of scar tissue, you can't get all the way around the colon, but you really want to examine it well. This is a good test in that situation. What about capsule endoscopy? People have heard of our capsules that we use to examine the GI tract. I don't know. It's a little camera within a big capsule. And you swallow it, makes a little trip like the Fantastic Voyage down your down your GI tract, and you poop it out. We don't want it back. And it takes a movie. But the problem, and so patients often ask us, I've heard about this capsule, can I do that instead of a colonoscopy? It doesn't examine the colon well. Colon's too big an organ and it's not inflated when the capsule goes down, and the capsule can't be steered or anything like that. So it doesn't examine the colon. We use this to examine the small intestine. It's just the right size to get really good pictures of the small intestine. And then when we use that mainly is when someone's had some obscure bleeding. I mentioned anemia as a cause of, or a finding that we sometimes see when people have colon cancer. Well, there are a lot of other things that can do that, that can cause bleeding as well. Well, usually when someone's iron deficient, do a colonoscopy, do an upper scope, and if we don't find anything, then we need to examine the small intestine. So we will often use a pill camera for that. So it's not really an option. Pass it on to your friends for instead of a colonoscopy. Okay, so what about screening? The problem is, in the past, insurances haven't been very good about paying for colonoscopy. There's still some glitches because patients' insurances will say, we'll pay for screening colonoscopy, but if we do the procedure and we find a polyp and take it off, they say, oh, now it's a therapeutic. So they change, but we don't want to be doing 2 procedures, take you out of action for 2 days, the risk of that. So that's still, I think they're still working on trying to get insurance companies that say they cover screening colonoscopy to cover taking out the polyps as well. A lot of patients are embarrassed by the procedure. You know, obviously it's not you know, you're exposing yourself. There's just a certain amount of embarrassment that some people feel with that. You know, we see this every day, but I can still understand that. But it really, given the downside of not having a colonoscopy, this should hopefully not keep people from having colonoscopies done. Inconvenience. It is inconvenient because the sedation involved or anesthesia involved with having a colonoscopy, as well as the prep, kind of takes you out of action for at least a day. But the good thing is it's rare to need them very often, you know, and if you have a clean colonoscopy, you're good for 10 years. You have polyps a little sooner, but it's not every month or a very frequent procedure that needs to be done. So this is the other thing that gets patients, and that's the prep. I think the question I'm asked most often is, when are you going to invent a better prep? And people are working on that. I'm not sure that they'll come up with something that's really, the problem is in order to safely clean someone out, you have to have something that gives them diarrhea, and it can't cause them to have fluid shifts in their body where it damages their kidneys, where they get dehydrated. So the prep I use most commonly is something called Go Lightly. You may be familiar with it. It's a gallon jug of a non-absorbed laxative called polyethylene glycol. And that does a good job. It's very safe. We can use it on patients that are dialysis patients. It doesn't cause electrolyte and fluid shifts. That's part of the reason we use it. It's very safe, and it does a good job. There are other ones where there's less volume involved in the prep that don't clean out as well, and we can miss small polyps. We can miss things. And if you're having it done, you want it done right. So we try and go with Go Lightly as much as possible, but there are occasionally patients that have had Go Lightly, they can't tolerate it. They get one glass and start vomiting. So we go to something else. Now, what are the new preps? Oh, well, and then while I'm on that, you may have heard of the pill prep. We don't use it here. It's a phosphosoda prep, and it's 32 little pills. You have to drink a lot of water with that. There was a liquid form of that we used for a while. That's been taken off the market. It caused kidney damage in some patients. The pill prep can do the same thing. It has a red black box warning from the FDA. Hasn't been taken off the market, but I just would not use that. You know, when there are safe preps available, you know, just for convenience sake so someone doesn't have to drink as much, I wouldn't do it. It's just not worth the risk of having to be on dialysis or something like that. As far as the new prep, the one thing I've seen, is they're basically coming out with, it's kind of like power bars made out of the active ingredient in Go Lightly, and then smoothies with it. And you do several of these bars and a smoothie and a bunch of water, and it works as well as Go Lightly. It's probably the same amount of volume involved, but it's more water than a mix of the Go Lightly. So that's in a study phase right now. We'll see how it works, but I think part of the problem is that I can anticipate that some patients will take the medicine but not drink enough water, and it may not work as well as it does in studies when it's a very controlled situation. So, what do we do if we do a colonoscopy? If it's clean, in other words, no polyps, usually it's 10 years. It could be 5 years if the patient has a first-degree family member that had colon cancer under the age of 60. Now, if there are adenomatous polyps, that patient is now at higher risk. And it all depends on the polyps. So say they had a really big polyp, and sometimes the margins of the polyp are not clear, and so we'll want to take a look in a few months to see if we got all of it. If it's just a small adenoma, 1 to 2 small adenomas, less than a centimeter, then it's usually 5 years. If the prep is really poor, then sometimes we'll say, even if we didn't see anything, we'll say that we would recommend another one within a year or so. And then if someone has cancer, then we do testing to see what stage it is, have patients see oncology and surgery, and then if they have a fairly early stage, it's not widely spread, then usually after 1 year we do another colonoscopy, and then if there are no polyps or anything increasing the need for doing it sooner, usually 3 years, it all depends.
So the first thing we're going to talk about is basic cancer risk reduction and how many people have heard be a healthy weight. Being overweight and obese is absolutely problematic in several of our highest risks, most complicated cancers. So how do we take care of that? We are physically active, and what you just did right now, 2 of those exercises are actually from a program from Tufts University that have been shown to reduce the risk of cancer, heart disease, and breaking bones as we age. So if you ever want to learn more about that, it's very low intensity but very strong and research based. You just have to let the dietitians know. It's a very simple form of exercise and very healthy. You need to be active 30 minutes a day. Does that mean you have to run a marathon? No, but it means when you go shopping, you need to park at the end of the parking lot. Or you need to take the stairs, not the elevator. But then, I call that being healthy lifestyle. I don't count that as your physical activity. But again, you don't have to run the marathon, but you do need to do walking or go to the gym, swim, or some of the other low-intensity programs. That sweet little lady's still on PBS for chair exercises, things like that. Or you can go to the Y. The important thing about cancer here is why do we want to reduce our risk of fat? Men in the abdomen, women in the behind and the thighs. Why do we not want extra fat? Somebody knows this. I know you do.
Slow circulation, fat circulation.
That's a great point. I've never researched that, but that's a good one. So he said maybe it slows circulation. So in women, we have hormone-producing fats in our inner thighs and our bottom. And for men, we have hormone-producing fats in our abdomen. Those fat cells increase your risk of cancers. That's why we want to be lean. We don't want to have hormone-producing fats, okay? What else do we want to do? We want to avoid sugary drinks and sugary foods. So these 2 are the exact same calories. One looks a lot prettier. The other one doesn't look pretty. My rule is if it looks pretty outside of Skittles, it's probably good. If it doesn't have a lot of colors on it, it's not very good. And here's the one that threw me. I'm constantly learning these things because I love food. I'm going through the Starbucks line because, yes, I love my coffee. And I was going to get the banana bread. And she says, don't you want the chocolate bread? And I said, no. She's like, it's got the least calories on the menu. The chocolate bread has frosting on it. Have any of you seen the new chocolate bread, or am I the only Starbucks junkie in the room? So the chocolate bread is better than the lemon bread and better than the banana bread. So you really just can't win at restaurants. That's the point there. So eat in moderation. But it also doesn't have a lot of color in it, so it's not a food we should be eating regularly. It's full of a lot of sugar. This is one thing we don't think about. Soda, soda, and soda. In my practice here at the clinic, this is probably the #1 thing that we do for weight loss. I can get you to lose 40 to 50 pounds in the next year just by cutting out soda if you're drinking it. Soda is packed in calories. And then people say, well, what about diet soda? What about diet soda? And why not? Why no diet soda?
It stimulates the brain to think that you had sugar and then it produces the hormones.
So he says it stimulates the brain to think you had sugar and stimulates the hormones. I don't know that one. I'll have to look that one up. However, your sugar-free sodas and all of those actually have been linked to increase obesity even more, heart disease and diabetes, just from the chemicals in them. And not to mention, and all of us wonderful women in the room, we already are at high enough risk for osteoporosis. Phosphoric acid in soda pops is just killing your bones. Get rid of it. This is the only thing in the world of nutrition that I have not been able to come up with the word moderation for. If you can find something good about soda pop, I challenge you to bring it to me. Because I can find something good about chocolate, I can find something good about anything, because I love food, but I haven't found anything good about pop. Does anybody want to test me? Oh. Well, that's different. That's just a carbonation in the water. So club soda or carbonated, those new self-carbonated machines, that doesn't worry me. It's the chemicals that are then added to it, or the alcohol, or something like that. Okay?
So what if they had like diet, other drinks, like diet cranberry juice? Or
Yeah. So it really depends on the ingredients that are in there. Any diet drink, from juice to just about anything. It really depends on the ingredients. I would prefer you go with something that's just naturally less in sugar. So if you're going to buy juice and you're going to buy cranberry juice, because we all like cranberry juice for our bladder, I just want you to put 2 ounces in the cup and then dilute it with 2 ounces of water. Just dilute it. It's not bad for you, but it's not great for you. And only 1 serving of juice per day counts as a fruit. You can't have 3 cups of juice and call it 3 fruits, right? Excellent. So hydration. My biggest pet peeve is water, 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 and water. And here's where you have all those questions about, well, what can I drink? And does it have to be water? It really needs to be water. But I know that not everybody in here is going to drink water. So you see on here, down here under your caffeine, your sodas, coffee drinks, energy drinks, all of those, they're just dehydrating and they're bad for you. Your artificial sweeteners. Now, if you have diabetes, this is not the same presentation for you. This is cancer risk reduction. We don't want to overconsume sugar, okay? Overconsuming sugar causes a lot of problems in our body that causes cancer. So some people will go to sugar-free products, and you'll find these sorbitol, xylitol, all these other chemicals in there. But they can cause a lot of problems themselves, and normally when I see people, it's causing a lot of diarrhea. It's usually what I'm catching in those. So your artificial sweeteners, especially in your juice, it's not necessarily ideal. But if you have diabetes, we really need to weigh the benefit versus the risk of those. If it were me, I'd drink water. All right, your sodas, all that stuff. Who wants to know about bottled water versus tap water? Okay, well, most bottled water is tap water. The only place I really know of where tap water is a problem is in Helena. Does anybody know why? Does anybody know the issues in Helena? So Helena actually has a high grade of pharmaceutical waste in their water. And I lived there for a while too, and it's a big issue. So that's the only place where I would know where you would not drink tap water until they start to really get that clean and figured out.
Roundup? Have you ever
Sweetheart, I was born and raised in Roundup on that water.
so that water?
It tastes awful and it smells awful, but it's actually nothing wrong with it. It gives you a couple minerals that you don't get in your diet. If you can get it down, it is safe. I'm just going to say that. Now, well water, if you have wells, you need to have your well tested. If you are going through chemotherapy, you must have your well tested. There has been multiple times in my, 12, 13 years of practice where we have had well testing come back with bacteria and whatnot, and if you're on cancer treatment, that's not safe, okay? Roundup water has never been proven to be anything other than smelly and ruin our pipes.
Yeah, that's.
Well, you just took me back to cleaning the water heater when I was a kid. You don't even want to know what happened that day. All right, the next thing we do for cancer risk reduction, grains, veggies, fruits, legumes. So who has great ideas that they want to share with the group on this? What's your best way to eat fruits and veggies? Raw, I loved that. Somebody had my memo right in their head. So fresh is best, frozen second best, and canned, if only canned in their own juices, and then rinse them. There's nothing wrong with canned vegetables, just rinse them. They don't have as much nutrition, but we live in Montana. Do we have fresh vegetables all year round? Certainly not in Roundup. I am not. It's just not pretty in the grocery store. In Billings, we have quite a few options, but some places, you live out in Muscle Shell or up in Harlow, you may not have access to those regularly. So canned is okay. You just need to use it correctly. We're just trying to get rid of the sodium, okay? Your fruits and veggies have all those really big, fancy phytochemical names and all that stuff in there that are your cancer risk reductions. So which one should you eat? Tomatoes, really good in preventing prostate cancer. Watermelon, broccoli, and red onions. Those ones are packed in your phytochemicals, really good. But the point is, you need to eat the rainbow every day. Again, not Skittles. Kelly's going to laugh. I get so much trouble from the nurses when I say the rainbow because they come up with M&Ms, Skittles. But every day you want to eat red, orange, yellow, green, and blue fruits and vegetables. How do you know if you're not eating enough fruits and vegetables? By the number of bowel movements you're having. Do you guys know how many bowel movements a day is normal and healthy for a good colon? Should we put the doctor on the spot? How many bowel movements a day are you looking for? 1 to 2 would be great, right? If you're eating your fibers, your whole grains, your beans, your fruits and veggies, you're going to be somewhere in the 3 to 5. Some people even can go as far as 9 bowel movements a day. The more you clean out that bowel, the healthier it is, okay? Some of you are like, oh, that's awful. Well, you might have painful bowel movements. You might have difficult bowel movements. If you're having small, regular bowel movements all the day long, you don't even know it's different, okay? Having a bowel movement every 3 to 4 days, that's not ideal, okay? You need more water and more fiber, okay? And this is my favorite quote. I really regret eating healthy today. Said no one ever. All right, this is usually a question I get a lot, so we're going to bring it up. Red meats, red meats, red meats. Who has heard red meat causes cancer? Oh, we have some really up-to-date people in here. So red meat is fine. It's just not fine if we eat it every single day. And it's not fine if we're eating it in 12, 16, 18, and 24 ounces, right? A deck of cards, 3 ounces is a serving of a red meat. You shouldn't be eating red meat more than 2 to 3 times a week. Then it becomes problematic, okay? But what meats are we getting into that we know cause cancer and that we actually know contribute to Parkinson's disease and makes the side effects of Parkinson's disease worse? Processed meat, nitrates, bacon, Canadian bacon, your hams, Spam, all of those things. And 5 years ago, this was a really hard talk to give because we didn't have any options. But healthy consumers are demanding more, and you can find no nitrates, so nitrate-free lunch meat, bacon, you can find it everywhere. But here's what not a lot of people know. That nitrate is the preservative that makes it shelf stable. So if you're going to buy nitrate-free bacon, you can't buy enough for 1 to 2 weeks. It's going to turn green and it's going to smell foul. Okay, so if you want fresh meat, you need to eat it in a timely manner. Okay, you can freeze it and use it that way, but you can get Sam's Club, Lucky's, Costco, even Walmart starting to pick up on it. I haven't seen a whole lot of nitrate-free products at Albertsons lately, just kind of in there, but yes, I'm a grocery store addict, so I know what's where. Yes, sir?
Does the label tell you?
Does the label tell you? That is such an excellent question. Does the label tell you? Here you go. You get the cheat sheet. The label under the ingredients, let's see if that's the next slide. The label under the ingredients. So you have this on your label, and then it says ingredients under that, right? Most of you have looked at a label. Under ingredients, it will say nitrate, sodium nitrate, potassium nitrate, all sorts of different nitrates. I don't care which nitrate it is. I just care that the word nitrate is there, okay? Now, you can find foods processed with celery salt. Now, if it's processed with celery salt, it still has to put the word nitrate on there because celery naturally contains nitrates. That is an exception to the rule that I will make. It's still not great, but it's not a chemical nitrate that your body is not used to. So celery salt preservative is okay, and you will see that a lot on the market, especially nowadays. It's really becoming more popular, okay? So that's where you find nitrates. And on your product, on the front, it can say all natural. That doesn't mean anything. If it says all natural, you can flip it over and you can still find nitrates. You have to read the ingredients, okay? Preservative-free is the word you're looking for, but that's actually not regulated by the government, so it doesn't have to mean there's no nitrates, okay? So food marketing is very confusing. What about nitrites? Nitrites and nitrates are the same thing. It's just a form. ITE or ATE is just a form of the stage that it's in, okay? So that's our nitrates. So that one, I'm just really glad we have stores now because I love bacon, and giving up bacon was really hard. Of course, they can't have it all the time, right? Because then it causes heart disease. And then alcohol. So this is the most common question I get. 2 drinks for men, 1 for women. So I don't ever drink during the week. So when I go out with all my friends and we have a social evening out, do I get to add them all up? You've all thought this, haven't you? This is what we get. Can you add them all up? No. It is overconsumption at any point that does increase your risk for cancers. Alcohol is a very, very big deal for BRCA-positive breast cancer. There's some of the genetic cancers where alcohol intake has actually been proven to be very harmful. So, you know, if you're a genetic predisposition for cancers, come see us. We'll help you figure all those things out. If you're not, you can enjoy a few drinks here and there, but please don't overindulge and drive. Did anybody get that? All right, so the whole talk we go through what not to do, what not to do, what not to do. This went over the top of my supplements. It wasn't supposed to be on that slide. All right, well, underneath that is probably the one question that you're all asking. Can you take supplements? Your over-the-counter vitamins, minerals, echinacea, ginkgo. Who wants to know about that? All right, so are any of those products regulated by the government? And what does that mean? That means there are no safety parameters in place. So when you buy yogurt at the store, what the label says is exactly what's in there. And if it's not, they're going to be sued for a lot of money. Like the olive oil company, they like to put light on the label, but they spell it L-I-G-H-T. So everybody thinks it's low fat. Actually just means it's light in color. That's it. If it's extra light and then the extra virgin, those mean flavor. So she was right on that too. So it's color and flavor. So they actually lost a lot of money because even though that wasn't L-I-T-E, it was very misleading to customers and consumers. So food, you're very safe. But you step over into the world of probiotics in a capsule, you don't know what's in there. You can't guarantee what's in there. So I'm not saying that all probiotics are bad, but there's certainly a lot of good foods now that have them in there, and there's a pharmaceutical grade probiotic as well. It's pretty expensive, but if you have inflammatory bowel disease or something like that, it's worth getting the correct one. But the point being, they're not regulated, they're not safe, we don't recommend them. If you eat your colors of the rainbow every day, you should not need a vitamin, a mineral, ginkgo, echinacea, any of those. Question?
So, let's say by vitamin D3,
Okay,
are you saying
no, that's the caveat. Vitamin D is the caveat, and here's why.
vitamin C? What about
Nope, nope,
all those things over the counter?
nope.
What, they don't include those ingredients in there? It's just a fake?
They can be. You can look up studies on the brand you're using. The most recent study of what is in these vitamins and minerals, you can look at green tea extract. Look up the research on there. 9 out of 10 of those is contaminated with dangerous levels of lead. Okay, so you just don't take them. But iron, vitamin C, all of those foods, when you take those vitamins, you maybe get 30 to 50% out of that. So eat the orange and you got enough vitamin C for an entire day, plus you got all these other vitamins and minerals, plus you got water. Nobody likes to get enough water. Okay, there's no food faster than fruit and vegetables. So when you think fast food, from here on out, you're going to think fruits and vegetables on the go. Okay? All right, so that's your over-the-counter vitamins, minerals, etc. You want to learn an easy way to get foods and all of that? Eat the rainbow every day. Keep the banana, keep the orange. You had 3 different colors out there. That was great. And the cancer risk reductions. The research shows vitamin C, vitamin E, those alone during cancer treatments actually protect the cancer cells. We require that you stop them all. They can increase the risk, increase your cancer production, decrease the effectiveness of your treatment. Very dangerous. Same exact ingredients from food, never shown to be harmful, always shown to be helpful. Okay? So vitamin D is not a vitamin. It's just been called a vitamin for so long, they decided not to change it. Vitamin D is a precursor to hormones, and vitamin D has been shown to be so beneficial and healthful that yes, we do recommend you take vitamin D because it's not in our food source. Okay? It's not really anywhere that we get it. Okay? Regularly, and we live in Montana, we don't get a lot of sun. Okay? Calcium. If you're not a food eater with calcium in it, you can take calcium and vitamin D. So we do calcium, vitamin D, and that's if you're at risk. If you're eating well and doing weight-bearing exercise, you don't need calcium. But if you're not eating well and you're the typical American that's go, 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 not eating well, not taking care of themselves, well, you got to weigh the risk versus the benefit. To me, that would be a benefit, especially if I'm having a bad month where I'm just not where I should be with my nutrition and I'm taking care of everybody else.
What
Yeah.
about coffee? You never said anything about that.
What about coffee? Everything in moderation. Regular. See, and here's the hard thing about a group. If you have heart disease, you need to listen to your physician. If you don't have heart disease, coffee, regular, 1 to 2 cups a day, is better for you. Decaffeinated goes through a very intense chemical process, and that isn't very good for you. So if you have heart disease, you've talked to your doctor, and they probably guided you on water-based decaffeination and all of that. Nothing wrong with coffee. Maybe wrong with what you put in it. That I don't know.
Since vitamin D is naturally produced by the skin,
Mhm.
not so good in the winter, and I take little things of vitamin D, where do they get the vitamin D from?
Where do they get the vitamin D from? Tons of different sources. That's a huge conversation. There's not just one source of vitamin D. So it comes from several. It can be made in a lab, it can be produced, it can be extracted from foods. Vitamin D is not a straight, it's not like fish oil, any of those, okay? So that one's pretty complex. But vitamin D in general is pretty good. You can take it. Now, you don't want to be taking vitamin D unless you're seeing your physician because, again, I said it's a precursor to hormone production. You can take way too much vitamin D. You can also be a person that's genetically predisposed to make enough. There's actually people that you make it for 1 to 2 months in the sun, you store it, you're fine all year round. You know, you're going to hear lots of people that say you can't take too much. My job's to find the people that are taking too much and help them get better. You can take too much. You shouldn't be doing that without a physician oversight.
How about the fish oil?
Fish oil, again, it depends on the medications you're on. I wouldn't take fish oil. Taking fish oil every single day is equivalent to eating fish 3 times a week. Eating fish 3 times a week, you get a lot more out of it. You can't dunk it in butter, but you get the point. Don't coat it in eggs and all that stuff. But yeah, fish 3 times a week is equivalent to fish oil every day. Now, if your physician has prescribed fish oil, that's different, okay? If you're needing to take it with a heart disease or something like that. But fish is better. Food is always better. It's always better, safer, easier. Any other questions? You guys have been awesome.